Good morning and welcome to the next session in the Texas MPN workshop. This session will focus on interferon, and we have talks from Dr. Richard Silver from Weill Cornell Medicine in New York, and following that will be Jean-Jacques Kiladjian from the Hôpital St. Louis in Paris. To start us off, Richard Silver from the Weill Cornell Medicine in New York with his talk on traditional interferons.
Good morning, everybody. It's a pleasure and privilege to share this virtual workshop with you. And I'm sorry we all can't be together in person, but the most important thing is that we're all in good health. So today I've been charged with discussing the traditional interferons and to summarize the DALIAH and the MPDRC 112 study. So first I'm going to make some general remarks about interferons. They've been discovered more than 50 years ago, and they're proteins. And basically, for the clinician, what you should remember is that there are three types of interferons: type 1, type 2, and type 3. Type 3 interferons are very similar in activity to type 1, which are known as viral interferons because they are developed in the body in response to viral infections, as the name so implies. Type 2 are the immune interferons, and they're more involved in cellular immunity and in antigenic responses. The type 1 interferons are of two general types, alpha and beta. It's of interest that the beta interferons are those that are really addicted to the respiratory endothelium and cause so much trouble in the recent COVID epidemic, whereas alpha interferons are more widespread with respect to this stimulation of genetic responses once they occur in response to viral infections. So are there qualitative differences among the interferons? This is a question that all clinicians ask, and it's very important because in selecting interferons for use, one would want to pick those that have the most efficacy and the least toxicity. The evidence to date is quite substantial that there are quantitative differences, but no qualitative differences in activity, except for those that I've mentioned already with respect to the different types of interferons. But all type 1 interferons have similar toxicity profiles. The differences we see in the clinic are usually the results of the doses used, the individual variation and characteristics of the patients, the way the clinician administers the interferon, and the reaction of the patients on receiving it. And of course, the differences we see in clinical trials are the heterogeneous methods of response evaluation that have only recently been standardized. However, all put together, it would appear that the quality of life might be better with pegylated forms of recombinant interferon alpha. So there are three general types of pegylated interferons. There's recombinant interferon alpha 2b. This was known as PEG-Intron, used to be manufactured by Merck and initially by Schering. It has an unstable urethane bond between the PEG and the interferon molecule, which causes it to more likely hydrolyze and therefore a more rapid release of interferon with a shorter half-life. Schering and Merck have both stopped manufacturing this drug, unfortunately. PEG interferon alpha 2A has a more stable amide bond, a longer half-life, prolonged plasma concentration, and therefore presumably a prolonged efficacy with less toxicity. Likewise, Genentech is stopped and Roche have stopped manufacturing PEG interferon alpha 2A for general clinical trials, so those patients who are receiving it from myeloproliferative neoplasms will have adequate supply, according to the last information that I received. And the new kid on the block is RhoPEG interferon. It has only one isoform of interferon and compared to 11 or 12 isoforms of interferon alpha 2A or 2B, and presumably that may affect its effectiveness or toxicity. It's administered every 2 to 4 weeks Very effective. It's been approved for use in Europe, and there's an FDA submission pending in the United States. Now, why are interferons of interest to hematologists and oncologists as well as to infectious disease folks? Well, first of all, they induce expression of pro-apoptotic genes. They inhibit angiogenesis and alter the microenvironment. They enhance immune response against malignant cells and suppress proliferation of hematopoietic progenitor cells. And they promote cycling of dormant malignant hematopoietic stem cells as well. And most importantly, they affect megakaryopoiesis. So that's why interferons have been used in PV, ET, and in our institution in early phase of myelofibrosis. But we've been charged with examining polycythemia vera today. So let's see what's specific about interferon in PV. So specifically in polycythemia vera, interferon alpha antagonizes the action of PDGF. This is very important because of the fibrosis that we see in this disease as it evolves. It promotes stem cell cycling, a very important observation first made by Anne Mullally in the Dana-Farber some years ago. And it's anti-angiogenic, a note made by Dr. Folkman many years ago, which applies not only to PV, but also to all forms of cancer. But note that it directly represses megakaryopoiesis, and we all know that that's critically important in PV. And it's involved in JAK-STAT signaling, and of course, we know that PV is characterized by JAK2 V617F. So one of the limitations of interferon therapy, we have to be very fair about this. I think without any question, the toxicity, as I said, is the same among all interferons. It's probably decreased with the PEGs because of the blood levels are more sustained and they are not abrupt as with using daily doses or 3 times a week doses with other forms of interferon. Most important, the doses relate to the side effects, and therefore, putting it a different way, the side effects are dose dependent. And most of the typical early symptoms are flu-like symptoms that occur shortly after the injections, which can be handled easily with analgesics. And with the doses that we use of 45 micrograms to begin with, they're very uncommon. On sustained use of these drugs, we do see sometimes chronic fatigue, some evidence of depression, alopecia, and most important, sometimes liver toxicity, but we treat 2 times the level of the transaminase elevations, and in those cases, we don't experience any difficulty. Most important are patients who have autoimmune disease, and as you know, some of the side effects that we see in such things as the SARS virus are related to interferon overexpression, so we're very careful in patients who have rheumatoid arthritis or any evidence of an autoimmune hemolytic anemia. That's probably a contraindication to the use of interferon. Now, many folks with PV are in the older age senior citizen group, and so we're very concerned about any gait disturbance or any neurologic central nervous system dysfunction, and that has to be carefully evaluated before we embark upon interferon therapy. Noteworthy is the fact that many folks have gait dysfunction in the age over 65, and they don't seem to get worse with interferon, but this is an observation that really requires careful following. So the MPN RC112 trial was a randomized trial of PEG interferon A versus hydroxyurea in high-risk ET or PV as defined by the European Leukemia Net. And treatment was rather short. It was only up to 1 year. And if there was a partial or complete response, the drug treatment could be continued for 6 years. The goal was the CR/PR rate marrow response at the end of 1 year. As I just mentioned, a very short time frame indeed. Secondary events are as listed: MDS and myelofibrosis, leukemia, cardiovascular events, and of course, evaluation of toxicity. I might add that distinguishing JAK2 positive ET from PV is not easy. We recently published a paper in Hematologic, as did the French group, shortly thereafter, indicating that although the sensitivity of this distinction is easy, the specificity is difficult, and there's probably a 30% error rate in distinguishing ET from PV. So these studies must be looked at with a great degree of caution. So here are the results. They're rather not striking, and that's not unexpected because the follow-up is short, as you can see, 1.8 years. The treatment duration was only 86 weeks. There was a slight 24-month overall response rate of 60%. There was a overall response rate that was equivalent of about 70 to 80%. What was of interest was that there was a slight CR rate superiority of PEG, which was not overly significant with a p-value of only 0.04. So these results are really not overwhelming, showing any significant difference between these two agents, and not surprising because hydroxyurea is an effective agent in treating PV, but it doesn't have qualitative effects that interferon does. So we can conclude that the CR rates of high-risk ET and PV patients at 12 and 24 months were similar. PEG had a higher degree of grade 3 to 4 toxicity. The conclusion in this published study was that, which was published in an abstract form, was that both drugs could not modify the natural history of the disease. I listed that as a question mark because I don't think the evidence, even though I'm a co-author on this study, has been submitted as yet that the natural history has been changed. So let's take a look at the DALIAH study. That comes from the Danes, who have been very active in this field. They randomized 90 PV patients using low-risk, high-risk categories, again, according to the European Leukemia Net, which, as everyone knows, is low risk is folks under 60 with no history of thrombosis, and high risk is those over 60 with a history of thrombosis. The randomization for low-risk patients was between interferon alpha A and B. High risk was hydroxyurea versus interferon alpha A and B. So those were the shorter acting forms of interferon alpha A and B. So the dose of hydroxyurea was adjusted according to clinical response. Low dose interferon was used, as you can see here, and that's what we always advocate, starting with the lowest dose and working up, rather than with a high dose and working down. So the results in 90 patients show an overall response rate for hydroxyurea of 68, a partial response of 53, and a very low complete response rate of 16%. Interferon showed a complete response under the age of 60 of 33%, which was significant, but over the age of 60, only 9 partial responses. So overall, when you looked at the combination of the drugs and compared them, there was no significant difference among overall response rate, complete hematologic and partial hematologic response. The subsequent maintenance dose was higher for interferon. The toxicity discontinuation rate was higher with interferon, or the significant adverse events were comparable among the groups. So you'll note that of interest that patients under the age of 60, the toxicity was 52%, over the age of 60, 45%, so indicating that age didn't seem to strikingly affect toxicity profile of the patients. As I said, this depends upon the dose that was used, which has not been specified, its duration, and patient response and tolerability. So the conclusions were that the overall response rate was slightly higher in hydroxyurea. After 36 months, the complete hematologic response was higher but non-significant, all non-significant interferon group. The maintenance of complete hematologic response was longer for interferon alpha, and the toxicity-related discontinue rate was higher with the interferon. Putting all this together, I think we can say that these two short-term studies have not disclosed the superiority of interferon over hydroxyurea unequivocally. Both are effective, and we knew hydrea was effective from the days of the polycythemia vera study group because that's why it was instituted for treatment after it was shown that alkylating agents cause such frank development of acute leukemia. But we at Cornell have been looking at our 477 patients who've been treated with interferon. We have just submitted an abstract of this, a retrospective study comparing interferon versus hydroxyurea versus phlebotomy only. And this slide shows the results of those patients treated on an intent to treat analysis with either of the three modalities. The median overall survival for interferon treated patients was 28 years, for hydroxyurea 26, and for phlebotomy 21. The overall survival was 27 years, which is doubling of the time reported by Teferi not long ago in leukemia, in which the worldwide survival time for PV patients was only 14 years. So we think this is a significant advance in treatment when the drug is started early. Serial bone marrow analysis from our patients indicated that there was a much higher grade of fibrosis in patients treated with phlebotomy only. That is shown in the blue bars, and as you can see, over a course of 18 years, there is a progression of fibrosis in the phlebotomy-only treated group, which was 59 patients. In comparison, hydroxyurea suppressed fibrosis compared to phlebotomy only in 105 patients, but still was far inferior to that with interferon, shown in orange, 62 patients who had only minimal to modest progression of fibrosis, indicating that interferon improves the fibrosis and, as I mentioned earlier, overall survival, particularly when used from the onset of the illness. So the randomized studies have yet to demonstrate the efficacy of interferon, but this retrospective study in a large group of patients has indicated to us indications of the superiority of interferon, which we hope will be confirmed with the randomized trials in due time. I thank you.
And to follow that is Jean-Jacques Kiladjian from the Hôpital Saint-Louis in Paris with his updates on ropeg interferon.
Good morning. My name is Jean-Jacques Kiladjian, and I'm hematologist in Saint-Louis Hospital in Paris. And I will discuss today updates on ropeg interferon with you. These are my disclosures. Ropeg is a new generation monopegylated interferon alpha 2b with a very long half-life, meaning that the drugs remain really stable for a long time in the body and allows for an administration under the skin only once every 2 weeks and even once monthly in long-term maintenance, as you will see with the results of the PROD and continuation PV studies. It was approved 1 year ago in Europe for the treatment of polycythemia vera in adults without symptomatic splenomegaly. And this approval was mostly based on the long-term results of the PROD and continuation PV studies, And we presented, and I will share with you what we showed at the last ASH meeting in December 2019 with a 4 years update of this study, showing very nice responses and reduction of the thromboembolic risk in patients treated with ROPEG. So the PROUD-PV study enrolled high-risk patients with polycythemia vera who were randomly assigned to receive either ROPEG interferon or hydroxyurea. And the PROUD-PV endpoint was after 12 months of treatment. And after that point, patients, if they wish, could continue the treatment and roll over to the next study, continuation PV, on the right part of this slide. And the aim of continuation PV being to record and to collect safety and, of course, efficacy data on the long term and not only after 12 months of treatment, because it is already well known, as was shown before, that interferon treatment needs some time to achieve its main efficacy. So what I will show you now are the results after 4 years of treatment, 1 year in PROUD-PV, and then followed by 36 months treatment in the continuation PV study. The first information we have with long-term use of ROPEG is in terms of administration and dosing. As you can see on the left part of this slide, the proportion of patients who need only 1 monthly administration increased to up to 42% during the 4th year of treatment. And this is very important, very comfortable for the patients who have just to do one, usually self-administration, subcutaneously per month to control their disease. In terms of dosings, on the right part of the slide, you can see also that the starting dose was around 700 micrograms per month, and this could be reduced down to 531 micrograms per month during the 4th year of treatment. So long-term use of ROPEG allows usually to progressively reduce the dose and reduce the schedule of administration. That is also very important in terms of comfort for the patients. Now for efficacy, we can see that the complete hematologic response rates, meaning that the blood counts are completely normal without phlebotomy and an hematocrit remaining below 45%, that was already superior in the patients receiving ROPEG compared to the control arm after 2 years of treatment, remained durable over time, and at 4 years of treatment, 61% in the ROPEG arm had complete hematological response, compared to 43% in the control arm. Importantly also, when we looked at the rate of patients who were phlebotomy-free, you can see that this was again superior in the 4th year of treatment. In the patients receiving ROPEG, almost 80% of them were phlebotomy-free compared to 60% in the control group. Of course, what is important for patient safety is the reduction of major thromboembolic events, and indeed this was the case for both groups of patients, hopefully, with a quite low incidence of thrombotic events, 1.4% patients per year in the ROPEG arm and 1.2% in the control arm, showing that both treatments could clearly reduce the risk of thromboembolic events equally, and probably this low rate is also due to the fact that patients included in PROUD and continuation PV were mostly early PV patients, not late patients who had a higher risk of thrombotic events. Of course, we were interested to look at the evolution of the JAK2 mutation allele burden during treatment. And as you can see on this slide, again, a clear superiority of ROPEG after 2 years that again remains very stable over time, and 67% of patients achieved the molecular response at the 4th year of treatment compared to 26% in the control group. If we look at the absolute value of the JAK2 mutation, you see that the starting point for both groups was comparable, around 38% of JAK2 mutation, and this decreased regularly down to below 10% at the 4th year of treatment in the ROPEG arm, compared to no clear change and even a slight increase to 43% in the control group. And importantly, what we could see during this 4th year of treatment analysis is some patients achieving now complete molecular response, meaning that the JAK2 mutation is no longer detectable with an assay that has a sensitivity of about 1%. And you can see that 13 patients in the ROPEG arm achieve such undetectable level of JAK2 mutation over treatment compared to none in the control group. As you know, of course, in addition to JAK2 mutations, some patients may have additional so-called non-driver mutations. And this was studied by Dr. Kralovic in Vienna for the study. And he found a total of 95 of these additional mutations in 75 patients, the most frequent being, as already described in PV, mutations in the TET2 gene that was found in 32 patients. And as you can see on the right of this slide, we showed at the last EHA meeting 2 months ago that also the TET2 mutations could be reduced during treatment with ROPEG with a mean TET2 mutation allele burden of 32% at baseline that was reduced regularly down to 17% at 36 months of treatment with ROPEG. So showing that in addition to JAK2 mutation, ROPEG was also able to clearly reduce other non-driver mutations in patients receiving ROPEG. Of course, important results about safety to be sure that the drug is well tolerated. And you can see here a safety summary for the whole study period and showing reassuring results with clear similar proportion of patients experiencing adverse events in both groups of treatment. Importantly, if we looked at the serious adverse events, again, 20%, 21% in both treatment arms, and if we looked at treatment-related serious adverse events, quite low incidence with 2.4% of patients in the ROPEG arm experiencing such treatment-related serious adverse events. We know from many years and the long-term use of interferon that these drugs have some treatment-related specific class reactions that include autoimmune disorders and endocrine disorders and mostly thyroid problems. And as you can see on these slides, we were quite pleased to see that although these complications usual with interferon were present, they were seen at a low rate, 3.9% for example for thyroid problems. And also very reassuring, only one patient experienced depression, anxiety, and mood changes. That is a very low incidence for such a long treatment with interferon alpha. Another major endpoint, of course, with the use of interferon that is not leukemogenic or not mutagenic treatment compared to current chemotherapy like hydroxyurea, is to reduce the risk of secondary malignancies. Of course, it's too early in PROUD and continuation PV to draw any definitive conclusions, but the preliminary results we have are quite reassuring, as you can see on this slide. Only one patient experienced an evolution of his disease to myelofibrosis in the ROPEG arm compared to 1 myelofibrosis and 2 acute leukemias, unfortunately, in the control group that also had 3 cases of skin tumors that are quite well known possible complications of long-term use of hydroxyurea. So these are the results of the phase 3 study in high-risk patients with PV in need of a cytoreductive therapy. But another interesting new information was presented during the last EHA meeting, the so-called low PV study that was presented by Professor Barboui during the last EHA 25 meeting. It's a phase 2 randomized clinical trial comparing ROPEG to phlebotomy, this time in low-risk patients with PV. And Professor Barboui showed the results of a pre-planned analysis. This study included only low-risk patients, meaning that they were all younger than 60 years, and none of them had a cardiovascular history of cardiovascular events. And these patients were randomized to receive either the usual treatment by phlebotomy and aspirin only, or phlebotomy plus aspirin, and raw-peg interferon. And the primary endpoint was the proportion of patients responded at 12 months, the response being defined by an hematocrit below 45% without phlebotomy and absence of disease progression. Patients were then followed for the second year, but what Professor Baboui showed us is the results after 1 year of treatment for the first 100 patients who entered the study, because indeed this pre-planned analysis allowed to stop the enrollment because the endpoint was already achieved with these first 100 patients. As you can see on the left side of these slides, the primary endpoint was met by 84% of patients in the raw-peg arm compared to 60% in the standard therapy arm. And if we split this composite primary endpoint between hematocrit control with similar proportion of patients, another interesting finding is that the disease progression was not seen in any of the patients treated with raw-peg compared to 8% in patients receiving phlebotomy plus aspirin. Another interesting finding is that raw-peg could reduce the symptom burden in these patients with a global reduction by 21% of the symptom burden in the experimental arm compared to a slight increase by 10% in the conventional therapy arm. So this clearly raised a new question, and we proposed a perspective paper with Professor Baboui very recently in leukemia, asking if chateau reduction should now be prescribed for all patients with polycythemia vera, including low-risk patients, since we have now a drug that is efficient and safe. That's an open question. So to summarize, the US and all international guidelines now suggest to use either interferon alpha or hydroxyurea as first-line therapy for high-risk PV patients. And of course, individual evaluation of the benefit-risk balance for both drugs is key for the choice of the first therapy for one given patient. We have now the results on the long term of phase 3 PROUD and continuation clinical trials that established raw-peg as a major treatment for patients with high-risk PV, and the studies showed that it was superior to conventional therapy in the long term for achieving durable, complete hematological response, but also deep molecular responses. In addition, achievement of complete hematological and complete molecular response was seen only in a proportion of patients treated with raw-peg, underscoring its disease-modifying potential and opening the way for the evaluation of drug discontinuation. Now we also have the results of low PV study that should clearly lead to reconsider the management strategy of low-risk patients with polycythemia vera. Thank you very much for your attention. Hello, everybody. I'm Jean-Jacques Kiladjian. Welcome in Paris. Hopefully we cannot be together, but we have a wonderful meeting here in Texas. And it's a great honor to moderate this Q&A session because we heard and we can now discuss with the pioneer of interferon who started to use this drug in patients with PV more than 50 years ago, Dr. Richard Silver. So it's very nice to have you. And we already have one question, Dick, from Dr. Mesa, asking what is the longest duration of interferon therapy you have in your practice?
Well, that's a wonderful question, and it's great. It's coming from Dr. Mesa, and I want to take this opportunity to congratulate him for a wonderful meeting. And I must say it's unusual that on his first effort with Dr. Verstovsek that you've had such a fantastic international session. So the longest patient we've had on interferon has been 30 years. And we haven't stopped that interferon therapy because even though the JAK2 V6 allele burden has been in the order of 10 or 15%, the bone marrow biopsy, which we do routinely on our patients, is hopefully every 2 years at the least, has shown persistent hypercellularity and grade 1 fibrosis. So it was our feeling that if we discontinued therapy, that the disease might recur and or the fibrosis may progress. So this gives me an opportunity to point out that we feel that JAK2 V617F levels alone are not sufficient to determine whether or not interferon therapy should be discontinued. And we, in fact, reported this in Hematologic a couple of years ago, that there was not good correlation between bone marrow findings and interferon and JAK2 levels, so that in the presence of hypercellularity and grade 1 fibrosis, we tend to continue the medication, even though JAK levels may be low.
So just as Dr. Mesa's question was also for me, I have exactly the same experience with the longest duration for the moment for patients is about 30 years, just like you, but I'm the third hematologist taking care of them. So it was started by my previous colleagues. That's underline, I think, an important question, that is the tolerance of the drug, because you underlined in your presentation that in the DALIAH and also in the 112 study, there were quite an important rate of intolerance. And it's also, I think, maybe your experience that those intolerances often occur mostly during the first or the second year of treatment. And once you pass this kind of landmark, then patients tolerate it very well, and it's very rare to have late side effects. Is it also your experience?
Yes, JJ. And, you know, I think the French data and the Cornell data and the Danish data is very, very similar. So that between 3 different countries and hundreds of patients, our experience with interferon over the long term has been very, very similar. I also would like to ask you, if I may, do you follow, I understand that the French were doing a trial on evaluating bone marrow morphology in patients with low JAK levels. Do you have any update on that? I haven't seen anything in the literature as yet.
We have an ongoing study, but it's for patients with myelofibrosis mainly. And I think we have already about 500 patients that have been reviewed centrally, etc. So I hope we will have the results available in the coming weeks or months. So we also have a question about ET, the experience. What about ROPEG interferon in ET patients? I should say that for us in Europe, we have only the PV trial, but I know that in the US, you have a plan for an ET study. Richard, do you have some information about that? Specifically for ROPEG, I mean, the question is.
Well, I know there is a protocol for so-called high-risk ET patients and PV patients, and I know the application has been submitted to the FDA by Pharmacentia, and I guess there will be a ruling in the spring.
Okay.
Or maybe in the winter of this 2021.
I have a question from Dr. Mullally asking if we found any predictor for the complete molecular responses in the 13 patients who achieved this CMR in the Conti PV study. Well, in fact, no, we couldn't find for the moment any predictive factor for these patients. And I think it was the same in our local experience in more than 200 patients. We couldn't predict neither the complete molecular response or even the response and see the deepness of the response. Patients could respond with any baseline level, very low, sometimes very high, it doesn't matter. And we could even show with Isabelle Plot that the higher the proportion of homozygous cells, better the molecular response. But otherwise, we couldn't predict the achievement of complete molecular response, neither baseline characteristics nor the kinetics of diminution. And this reminds me a point that Anne raised yesterday, the difference between JAK2 and CALR mutations in terms of molecular response. Dick, do you have some experience about that? Did you treat patients with CALR mutation and follow their CALR mutation? Do you have some
Well, I would say first, with respect to PV, I absolutely agree, as we might anticipate with what your statement was with regard to predicted responses. We can't predict who is going to respond to interferon or not. We have not systematically looked in ET whether or not CALR patients respond better than JAK2 patients. But I would again remind folks that the overlap between JAK2 positive ET and PV, there is a 30% overlap. So a lot of the literature that you read about ET JAK positivity may be contaminated in the order of 30% with PV patients, because many of those patients did not have red cell masses that Dr. Kiladjian and I do routinely and in our institutions, and B, they didn't have bone marrow biopsies, so that the diagnosis was really based on clinical examination and the WHO 2016 blood counts and or the 2008 WHO criteria, which we have shown are completely inadequate. So you have to be very careful when you read data about JAK2 positive ET patients and compare it to PV patients. Would you agree with that, JJ? You wrote a paper on that.
Yes, absolutely. I agree. This was discussed nicely yesterday by Dr. Spivak, and I fully agree that we have to be very careful in the diagnosis of these patients and don't put everything together, because there may be some differences in terms of response. Regarding the deepness of the molecular response, I think another very important point anyway is the duration of treatment. And as you could see, as we knew already, but of course what is clear from the PROUD and continuation PV, you saw the curves for achieving these molecular responses. You have to be patient, at least 1 year, to achieve a significant decrease in the JAK2 allele burden, and don't be desperate. It doesn't reduce within the first months. It takes time with interferon to achieve these important deep responses. But once you're there, there's a good chance of maintaining this response on the long term.
Yeah, I think a year is even a little early, JJ. I agree that that's when you begin to anticipate initial responses, but sometimes we really have to wait 2 years or even longer to get the maximum response. I think it's important to stress also that we want to start with the lowest possible dose and escalate the dose, and not start with the highest dose and come down. That is a mistake. So the lowest possible dose that is effective is what we use at Weill Cornell, and gradually increase the dose depending upon response and whether or not we can make the patient phlebotomy free, which we believe is most important.
Okay. I was also impressed by the survival data you showed, and we look forward to have the better details at ASH maybe, or in the publication. But can you give us some more information about that? It was quite impressive.
We've submitted a paper to a leading journal, so it's
Great.
under review as we speak, and we've also submitted an abstract to ASH with the update of 470 patients, which is, I might say with some pride, the largest single institution collection of PV patients, I think, in the world that I'm familiar with. But I can't give the data because it's really under advisory content at the present time.
Okay, I tried at least. I missed. Maybe also, can we have your thoughts about the role of interferon alpha in patients with myelofibrosis? That's an important point that was already touched yesterday, but what is your view? Which patients could benefit of this treatment?
Well, thank you for asking that question, JJ. As you know, I belong to that small minority of enthusiastic interferon users, including yourself and Hasselbach and Professor Gislinger from Austria. But I think, speaking for at least you and me and Hasselbach, that we believe in treating these diseases earlier rather than late, because this is a progressive neoplasm. We know from all the excellent presentations in the last 2 days that the inflammatory component of these illnesses play a role in the pathogenesis and progression of the disease, and it's best to quench this inflammatory component and suppress the malignant clone when it's smaller rather than later. So when it's smaller rather than larger, and begin treatment earlier rather than later. So beginning in 2013, we started treating patients with the cellular phase of myelofibrosis and intermediate one patients, and found with low dose interferon and being patient, because it takes a year or 2 or 3 to find marrow reversal, that this was an effective way of approaching these patients. And we reported 30 patients in cancer in 2017, showing a stability in or complete remission or partial remission in 70% of patients, and complete response in about 30%. It's important and that patients are selected who don't have multiple molecular abnormalities such as ASXL1, EZH2, etc., confirming Serge's data, in which he pointed out that patients with multiple molecular defects have a worse prognosis, and we also found that they have a worse response to interferon compared to those who don't have any molecular abnormalities. Thus, as one of the other speakers have already said, that it's very important to get the molecular profile when the patient is first seen in any of the MPN disease groups. That being said, a multi institutional study could not produce. We were supported by a pharmaceutical company, and we didn't produce enough patients for this comparative trial. So we only have single-arm studies comparing early treatment versus late. But we are hopeful that a cooperative trial randomizing early and myelofibrosis patients compared to traditional observation will be done in the near future to confirm our observations.
Thank you very much. And as you know, we have an ongoing study combining interferon and ruxolitinib in myelofibrosis, the so-called RUXOPEC study. And this gives me the opportunity to answer a question of Prithvi posed, asking if there's an update for this study. Not yet, but it also gives me the opportunity to discuss the molecular response beyond JAK2, and in particular for those additional mutations with poor prognosis. In this trial, combining interferon and ruxolitinib in patients with MF, we observed a very nice decrease also in bad mutations like A6L1, even TP53 sometimes in those patients. So I think there's a hope sometimes to target not only JAK2, but also other mutations. And in that perspective, there's also a question by Naveen about that. What, in your view, could be the best partners for interferon if we need to combine to something to achieve some better responses, especially in more advanced disease like MF with poor prognosis?
Well, I think the best combination is the one you're already performing in your studies, namely interferon with Rux. And I think the inflammatory component plays a great role in disease progression, and the combination of interferon and ruxolitinib is a wonderful combination. And the fact that you can reverse these molecular and genetic abnormalities that we are so afraid of is really very, very important. My only comment with regard to the Rux is that, as we all know, and we've heard this morning, is that, we don't know what the incidence of second malignancies are, the issue of infections, etc. Rux is not a completely benign disease. So if we're looking over a long-term treatment regimen, we've got to be very careful of the long-term effects of ruxolitinib. But I think in the short term, it certainly is a wonderful combination. And to be clear, the Danes and Dr. Hasselbach were the first one who really promoted the combination therapy along with the French. So I think that's a great combination to employ.
Thank you. We have a question by Dr. Moliterno asking, does the stem cell burden of JAK2 correlate with interferon response? I may start maybe to answer that question. I think we have two different types of response. Of course, the hematological response first, that is the one that we want to achieve in our patients to normalize their blood counts, to protect them from thrombosis. And in my experience, there's no correlation between this clear correlation between hematological and molecular response, at least at the beginning of the treatment. Then the studies we made with Isabelle Plot in the group of William, of course, showed that the highest the proportion of homozygous stem cells, better the molecular response. And heterozygous cells are more difficult to eliminate in our experience than homozygous cells. There's also a question more practical for you, Dick.
I agree with that comment, by the way.
Sure, please.
We, as might be expected, our experience has been the same as the Parisian experience.
Thank you. That's the Concorde between Paris and New York. The question is, if we come back to more practical issues, after starting on the lowest possible dose, how long before decision is made to increase the dose and to what level?
So that's an excellent question. And as I said, we use phlebotomy rate as a guide to our treatment dose with interferon. And as you well know, and as emphasized by Dr. Barboui and others, iron deficiency anemia that we see in PV has significant consequences, both with regard to symptomatic issues and fundamental physiological problems that really we don't pay sufficient attention to. But for sure, it's not good for patients to be continually severely anemic. So our goal is to make the patient phlebotomy free, hopefully by the end of the first year. So if a patient starts at 45 micrograms, let's say a Pegasus, within 2 months, if they're not had a significant reduction in phlebotomy rate, by 2 months, we increase the dose to 90 micrograms, wait another several months. And if they're not, if they have not shown a significant decrease, we raise the dose maybe to 90 micrograms, alternating with 135 every other week. And usually we never have to go above 135 micrograms of Pegasus. I don't know what that's equivalent with Ropeg. That's a little less probably than the Ropeg dose, but which was a fairly standardized dose. But as soon as we see the response, we decrease the dose of interferon so that, as Dr. Kiladjian mentioned, after the first and second year, the lowest maintenance dose is achieved, and you can maintain that dose on a patient for a long period. Now, the other parameter we do follow is spleen size, although I agree with, I think it was Dr. Permanjaru, that with Dr. Naveen, that we don't really know what the significance of an enlarged spleen is. I think this has been overly emphasized by the FDA, as has already been mentioned previously. But we do use that as a marker, and we try to follow the spleen as a guide to therapy. Hopefully the spleen will reduce in size as well. But our treatment goal is not to get the spleen to be non-palpable or not enlarged. Our goal is to make the patient phlebotomy free. And it's very important to recognize that prior hydroxyurea therapy over the long term even if patients have had hydria for a year or two, does not preclude a very substantial response to interferon given a long enough trial. As I said, the MPDRC trials are a little bit short to evaluate at the current time, but hopefully that will prove to be true as the PROUD studies and the Conti studies have shown.
Thank you. I think it's very helpful for our patients. A question regarding, you pointed out, and I fully agree that early treatment is the key for both the success and the tolerance of interferon. I'd like to know what you think of the results of the low PV study presented by Professor Barboui, and do you think this study should lead to a change in the management of the so-called low-risk PV?
Well, I hope so, JJ. First, I want to congratulate Dr. Barboui because of his intellectual honesty and great integrity. As you know, he was responsible for the ELN risk category of high and low risk PV. And most folks around the world, I would think, except for you and me and a few others, didn't really subscribe to that because we thought that it was more important to treat and make patients phlebotomy free, irrespective of risk category, because we knew even low-risk patients thrombose, as he has subsequently pointed out, and that iron deficiency has its own consequences. So we have always, like you, treated all our patients, irrespective of low risk or high risk, with interferon, insofar as possible. As you know, as you saw, not all our patients at Weill Cornell have received interferon. Some have received hydria because I don't take care of all the patients then. At any rate, I do congratulate Dr. Barboui for inaugurating the study, and I think that it would be his opinion that such patients now should be changed to low-risk patients should be treated with interferon. So I congratulate him for his change in position and his intellectual honesty.
Thank you. Yeah, I fully agree. There's a very important question, I think, also for you. Say, what is the risk of thromboembolic complication in interferon-treated patients? This is, of course, a major question because, of course, we want to achieve some hematological molecular response, but first of all, we want to protect our patients from those dramatic complications. So please, Dick.
So that's a great question, and a very pertinent question. When we reported the first 55 patients treated with interferon back in 2005, that was using interferon alpha 2B and some also being treated with Pegasus. But as I said, there's no qualitative difference between any of these interferons. That we observed no vascular complications in our patients treated some for as long as 20, with a history of PV for as long as 20 years. At that time, we had only treated patients for about 15 years. The subsequent analysis in our 470 patients has shown that people can develop thrombotic events even as long as 5 or 10 years after treatment with interferon, and we're looking very closely at that subgroup. And I can say, however, that the incidence of thrombotic events in our patients has diminished at least by 95% within 2 years, although we do see a thrombotic event occurring, notwithstanding interferon therapy, occasionally in patients who have been treated for more than 5 years. What that is related to, we still are currently evaluating. It may be unassociated hypertensive vascular disease or some other event, auricular fibrillation or not. We're looking into that. But you must understand that interferon lowers the white count, which we think may play a role in thrombosis and PV. It affects vascular integrity, which we know plays a role. It was shown beautifully by one of our speakers. It lowers the platelet count. And so it has all these effects on the coagulation process, which should, as we would think, predict a lowering of thrombosis, which it in fact has proven clinically.
Thank you very much. Just to follow up on that about our experience in PROUD and continuation, you could see that we were really pleased and reassured to see very few thrombotic events. 4 patients in each group experienced these complications, and 2 of the patients had these thrombotic events at time of titration of the drug, so at the beginning of treatment. So just to underline that we have to be careful. Of course, we want to start at low dose, be careful, etc. But nevertheless, phlebotomize the patients, keep the hematocrit low is important at the beginning of treatment to avoid any risk. So we still have some questions, but I think we are just on time now. I'd like to thank you, Dick, for the fantastic presentation and the great discussion, and I let you the final word.
Well, my final word is to thank you, and it's always great to participate in a Congress with you, and I'm glad we share so many wonderful memories together, and most important that our data is so close and confirmatory. And again, I want to thank Ruben and Serge for allowing us to participate in this great workshop. Thank you.
Thank you very much, and enjoy the rest of the meeting.